Here, maybe we click. Let's see.
Okay, thank you. So there are the objectives. My disclosures were mentioned earlier. So very quickly on growth hormone. So growth hormone is a peptide, obviously. It's produced by the pituitary. Growth hormone has effects both directly at the growth plate on its own, and it also has effects through IGF-1. Those effects, as many of you know, are primarily growth related, but it also has anabolic effects and effects on body composition as well. Dr. Thornton showed this graphic earlier, but again, this is a graphic showing you the kind of the chronology of growth hormone. So I guess the important thing to point out to you is growth hormone therapy for treatment has been around since the late 1950s. And from the late 1950s until the 80s, pituitary-derived human growth hormone was the treatment. Beginning though in the mid-1980s, we had recombinant human growth hormone through DNA technology. And so with that, we went from a scarce supply of growth hormone to a very abundant supply of growth hormone, which opened up many new indications and many new investigations with using growth hormone. And also even as well with the understanding of IGF-1 and its effects, recombinant IGF-1 also was available and used as treatment. So again, the growth hormone in the early days was very scarce. It was overseen by the pituitary agency and was really limited to children and to those with very severe growth hormone deficiency. And treatment was typically rationed 3 times weekly growth hormone doses. And that was pretty much the way it was until the 1980s when there were reports that emerged of Creutzfeldt-Jakob disease in some who'd received pituitary-derived growth hormone. And that really brought an end to its use. Fortunately, at that time, genetic or DNA technology had brought in synthetic human recombinant growth hormone. This was methionine growth hormone that was produced by Genentech. Because of the experience with safety, the FDA mandated safety registries to be done. And so that provided us with many of the useful information I'm going to present here as well. So again, here's a graphic showing you all some of the FDA approved indications and the timing for which they were done for growth hormone treatment. So what I'd like to do is move and talk a little bit about effectiveness and safety of growth hormone for the majority of the talk, and talk about this specifically with different conditions as well. But just as an overview, again, growth hormone, because it's called growth hormone, does improve linear growth. We have a lot of data on its efficacy. It has non-growth hormone effects as well, including effects on glucose metabolism, which can be concerning for risk of hyperglycemia. Certainly, if you have a severely growth hormone deficient child, you can see improvement in hypoglycemia. Lipids and body composition and bone density or bone health also are positive effects of growth hormone replacement. And then mood and cognition have been mentioned as well in adults who are on growth hormone treatment. And let me see if I can move this up to the top here so we can see. So again, this is looking both at just increase in body mass. So you can see that body mass on the lower illustration does increase in the first year with growth hormone and then levels off, and you have increases over time in lean body mass. So again, one of the beneficial effects of growth hormone is improvement in lean body mass. So let's talk about growth hormone deficiency and efficacy. So again, many of you with pediatric endocrinology backgrounds in the room kind of know this already, that growth hormone benefit or efficacy is in terms of height velocity is best in the first year, and then thereafter there's some diminishment. So here are a couple of illustrations from some of the registry studies. On the bottom left is from the KIGS database. And again, one of the things I'd like to point out in this illustration is, and again, something that many of us know, is that the more profoundly growth hormone deficient patients have better response to growth hormone treatment. So those with maximal stimulated values less than 5 versus those from 5 to the cutoff of 10. So again, looking at that, you can see that their height velocity is improved in both treatments, but is better so in those who are more profoundly growth hormone deficient. In this illustration, you can see again improvement in height velocity as well as improvement in height standard deviation score from the NCGS data. And you can see that this is maintained, although slower, throughout the 9 years this is reported. So with Turner syndrome, again, Turner syndrome is one of the things that are diagnoses that I think all of us clinicians entertain when we look at girls who are short. A couple of the things from a standpoint of diagnosis is the realization in Turner syndrome they have early appearance of growth failure. And if untreated, they can be quite short, well below the 5-foot mark. And growth hormone therapy has been studied in Turner syndrome. Most respond quite well. So mean height gain in a recent study was almost 3 inches. One of the things that was looked at initially was the question about whether or not earlier treatment versus later treatment had an impact. So earlier data had suggested perhaps that girls who were started as toddlers on growth hormone treatment who had Turner syndrome had better ultimate height outcome. And certainly they had accelerated growth. But a recent study reported last year showed that while there was improvement, at the end, the final adult height outcome between the early versus more later treatment, more around age 4 or 5, that there was no difference in the final height outcome statistically. And then idiopathic short stature. So again, idiopathic short stature is probably one of the more challenging diagnoses that we deal with in pediatric endocrinology, as far as just making the diagnosis and seeing what type of response we might have, and also looking at practical matters of insurance coverage as well. Height outcome or height improvement is relatively modest with idiopathic short stature treatment. Only about, in one quoted study, about 1.6 centimeters. And then based on some of the information from consensus statements, the suggestion is that 1 to 2 years of therapy with adequate doses of growth hormone should be sufficient to know whether there's going to be responsiveness for children who have idiopathic short stature diagnoses. Again, small for gestational age, a couple of things that need to be considered there. So again, there's many children who are born small for gestational age, and 90% or more of them will catch up. It's the group that fails to achieve catch-up growth by age 2 that we look at as far as indication for growth hormone treatment. And response to growth hormone treatment is generally good in small for gestational age infants or children. The challenge really in their case is other issues related to their small for gestational age status. So things like premature adrenarche, early appearance and rapid appearance of puberty can handicap the response to growth hormone, and also increase risk for metabolic syndrome and concerns regarding impaired glucose tolerance from use of growth hormone in that population. As with many conditions, I always point to the value of having consensus statements as a way to help with guiding us in terms of looking at how we're going to approach growth hormone treatment for different diagnoses. For Prader-Willi syndrome, Prader-Willi syndrome is a particularly challenging therapy. So again, individuals with Prader-Willi syndrome are going to have shortness by nature of their genetic condition, as well as growth hormone deficiency in many cases also. And in fact, growth hormone stimulation testing is not considered necessary after the diagnosis of Prader-Willi syndrome for growth hormone treatment. Therapy can be started early, and particularly early therapy has been associated with improvements in body composition and potentially in other areas not necessarily related to growth. The challenge really with Prader-Willi syndrome is obstructive and central sleep apnea risk. And so it's important to get baseline sleep studies and continued continued inquiry regarding obstructive sleep apnea symptoms in children who have Prader-Willi syndrome. From my personal standpoint, I had a patient who very strikingly taught me this. I had done a sleep study on him very early on and had started him on treatment. He had excellent improvement in his body composition, really has a normal body mass index, but with continued follow-up had some symptoms that were concerning for sleep apnea and had mixed central and obstructive apnea, even being a basically normal weighted young man who'd been on growth hormone for 5 or 6 years. Dosing can be problematic too when dealing with obesity. So there's weight or there's body surface area based dosing that can be used. There are contraindications as well for using growth hormone treatment in Prader-Willi syndrome, which I have listed here as well. And in particular, again, morbid obesity, I think it's important to counsel with families and explain to them that if their child already has morbid obesity, that growth hormone in and of itself is not going to be an agent for allowing them to achieve normal weight, but can be used in addition to other measures. So again, this illustration shows the growth promoting effects of Prader-Willi syndrome. So you can see the illustrations here of improvement from baseline where they're below the 3rd percentile to growth up to near percentiles that are closer or even in some cases exceeding the mean as well. And also improvement in the lower illustration on body mass index over time with treatment. There's some other things that are also considered as well too. So cognitive effects, effects on IQ, and of course, things that many of us are aware of in terms of effects on body composition, which can be seen with growth hormone therapy. And I know many families that I've followed who have Prader-Willi syndrome, really one of their main motivations early on is to help their child in terms of his or her motor milestones and to hopefully see some improvement in energy with growth hormone treatment. What about adults? And again, this is kind of relevant to me. So one of the things that I began when I joined Cook back about 14 years ago was involvement with brain tumor survivors and other childhood cancer survivors. And so particularly in the population of children I see with like craniopharyngioma or other brain tumors, growth hormone deficiency is a big issue for them. And it's unfortunately a bit of a hard sell oftentimes as growth is completed to get these individuals to continue on growth hormone treatment. And I think from my standpoint, one of the things I'm hopeful for with longer acting growth hormone is the opportunity to improve or even get buy-in to continue growth hormone treatment. So again, growth hormone treatment in adults, you're not talking linear effects on their growth at that point. We're talking really about some of the effects on quality of life, effects on bone health. I've had a number of kids with profound growth hormone deficiency in transition who have had low bone mass that has continued to improve and normalize with continuation of growth hormone treatment. The biggest cautionary issue again with adult growth hormone replacement is that often, or at least in the number of the patients whom I follow with hypopituitarism, you're already at an increased risk population because of risk for adrenal insufficiency and other problems that come along with hypopituitarism. So we've talked a little bit about efficacy. I want to go ahead and switch and talk a little bit about risks. So again, whenever we start someone on growth hormone treatment, we have counseling them in terms of the benefits and the risks. And again, the risks are listed here. These typically are relatively mild risks, so things such as edema and risk for myalgias and arthralgias, but there are more serious risks, so headaches with concern regarding intracranial hypertension, slipped capital femoral epiphysis, fairly common, and I think something that oftentimes is overlooked as scoliosis risk, because again, especially in adolescence where idiopathic scoliosis is more likely to be seen, following children on growth hormone treatment during that time window is important as well. And then of course, glucose tolerance. We have had the benefit, I think, of having many registry studies which have helped us to kind of capture information regarding adverse effects. And again, with long-term data, I think this is from NCGS. Again, we can see that by and large, adverse events are uncommon, but there are certain groups, those with organic growth hormone deficiency, so basically our hypopit group, Turner syndrome, and chronic renal insufficiency, who do have higher numbers of AEs and serious AEs, although deaths and other adverse effects. And again, this has been attributed in large part, or thought to at least be explained by issues, particularly with Turner syndrome, with other issues with their genetics or the medically complex picture of someone with chronic renal insufficiency. And so we all were on our way and happy and everything. And then back, gosh, it's probably been what, about 8 years or so ago, data was published from a registry study in Europe. This was a particular segment from France, which reported some concerning findings for potential morbidity and mortality related to growth hormone. And so we had to pause and wonder exactly what we're dealing with. And again, these were relatively non-complicated diagnoses. So these weren't the Turner syndrome or the CRIs. These were idiopathic growth hormone deficiency, so isolated or ISS or SGA. And again, the primary concern, and you can see, was cerebrovascular disease, so strokes, which was very concerning. And you can see that some of the factors that were cited in the study included higher growth hormone dose and smaller stature at the time of start of growth hormone. So that left, I think, a lot of us, and I remember going to national meetings wondering, okay, what does this mean? And so before I kind of come to the punchline on that, just a couple of things to think about, again, talking about risks for growth hormones. So stroke risk is increased in acromegaly. Also in growth hormone excess, there's cardiovascular mortality as well. Although it's important that the risk for stroke in acromegaly as well as in SGA is ischemic stroke and not hemorrhagic stroke, as was reported in the SAGE data. Then again, another thing to remind us is that this is not the first time we've had scares. So back in the 1980s, there was a concern regarding growth hormone and leukemia link, which ultimately has not proven to be true. So when we take a step back and look at the larger, the larger data, looking at SAGE and other countries that participated in this registry, there was not any additional risk that was found. So while this doesn't completely clear things, I think it does give us at least some reassurance that daily growth hormone at this point doesn't appear to have any long-term risks that are going to come back and bite us at this point. And again, this is the conclusion from the follow-up report on the larger group from the SAGE study. But again, I think it's still important, and this is especially important as we move into the era of long-acting growth hormone, that we need to consider that ongoing safety collection is going to be important. And again, I want to take a few minutes and talk a little bit about growth hormone and risk for cancer. So again, as many of you know, growth hormone is contraindicated in active cancer. And it's always a challenge when I talk to the oncologist about timing on what would be the appropriate time to start growth hormone in kids who have survived a malignant tumor, be it leukemia with growth hormone deficiency from radiotherapy, or a malignant brain tumor like a medulloblastoma. And again, there's some reason to take pause too, because there is an increased risk for colonic neoplasia and acromegaly as well. So again, that raises the question with higher IGF scores from growth hormone treatment, could this be a factor in cancer? So far, and a lot of this is the work of the Childhood Cancer Survivor Study and Dr. Sklar. There's been no data that would support an increased risk of tumors. If you look at growth hormone treatment if you look at second malignancies or recurrence of malignancies in those receiving versus not receiving growth hormone, the data is basically the same. And certainly if you look at especially the brain tumor survivors, meningioma, which again is related to radiation exposure, tends to be the highest likelihood. And again, one of our registry studies with Eli Lilly Genesis looked at and also found comparable information. So very quickly, let's talk about prescribing growth hormone. So again, prescribing growth hormone is fairly easy in some cases. Again, these are fairly straightforward, and most of us would feel that based on the data and based on the diagnosis that growth hormone therapy may be helpful in these particular patients. The challenge can be some of the other therapies, both from the standpoint of risk, such as in Prader-Willi, and then some of the challenges that many of us encounter in getting approval for like idiopathic short stature, or even growth hormone deficiency. So, but what about stopping growth hormone treatment? So there's some recommendations that have been given as far as stopping growth hormone treatment. That can be a challenge sometimes for families, but again, when bone age reaches 14 for girls or 16 for boys, particularly if they're approaching those ranges, I think it's important to begin the discussion about stopping growth hormone treatment and also potentially repeating testing off of growth hormone if you think that the patient is at high risk. Slowing at height velocity, particularly if you are verifying that you have adequate compliance. And then also there's recommendations too, in terms of when someone reaches a normal height or reaches near their mid-genetic height, because again, the older the child is, the more cost is going to be associated with growth hormone treatment. And again, there's mixed data. Certainly if you have someone with multiple pituitary hormone deficiencies, so hypopituitarism, the likelihood is that that individual is going to need lifelong replacement. And so it's not really necessary in those cases that you have to stop their therapy. But for others, their estimates range from about 25 up to 50% of childhood onset growth hormone deficient patients have adult deficiency, and so would warrant repeat stem testing off of growth hormone treatment. So again, very quickly, so we have a large body of data in terms of daily subcutaneous growth hormone. We have registries that have given us a great deal of information regarding safety. We have expert consensus statements as well. We have to consider as well both the challenges of starting and continuing growth hormone and transitioning patients that require it from childhood indication to adult indication. So to finish up here, some of these are things that Dr. Thornton had covered as well, but I guess the question is, so we have this wonderful tool of daily growth hormone treatment. Why would we want to move out into the unknown waters of weekly growth hormone? So just a couple of things. And again, I think the most important thing to point out on why the transition from daily to weekly is adherence. particularly long-term adherence and fatigue. And so there's been estimates, with any long-term therapy, this is not necessarily specific to growth hormone, there's only about a 50% reported adherence. And again, this is a table here that reports adherence in various studies. But anyway, they range non-adherence anywhere from 36, even up to 82% reported in one study. So again, why is that important? So again, you have poor height outcome, and which Dr. Thornton had touched on earlier. So those that were very adherent versus those that were less adherent, you can see that they had differences in this rather short duration study in terms of their height velocity. There's cost as well. There's potentially, again, for the more severe growth hormone deficient, quality of life and metabolic implications of non-adherence. So low bone mass, metabolic syndrome risk. What's been tried, and again, we have the neutropin depot, which I like to think of as endocrine medieval torture. I didn't have the chance to do studies, but came in as a fellow when I was on market and had a chance to see a few patients that used it, and it was not good. There's pegulated growth hormone, which there is nothing in the United States right now that's at market that's pegulated. There's somapacitan, which is the non-covalent albumin, fusion molecules, which is somatrogon, and then the transcon linker for Skytrofa. So again, the current leaders here that we have in the United States, I'm sure that there are others that will be potentially coming in, and we have, again, international growth hormone therapies that might actually come to the US as well. So with that, I guess the question right now, we're back to page 1 where we were with short-acting growth hormone in terms of looking at things such as tolerability and long-term safety. We have potentially the promise in long-acting growth hormone of at least non-inferiority, perhaps superiority. We have, hopefully, the big hook is going to be better long-term adherence with the weekly versus daily. Cost, again, remains to be seen also. So I also have a nighttime cooked children. So, whew, all right. I can't believe I landed that to the end there. But anyway, thank you all. So let me stop here and see if there are any questions in the audience or any questions on chat right now. I believe too, I think that we have a break after this, don't we? Okay. Well, let me ask people in the audience, for those peds endos, if you don't mind being put on the spot, what do you see as far as the promise and as well as the barriers for long-acting growth hormone? My goodness, we got crickets chirping here. Okay, well, go ahead and wrap up. I'm sorry, did anyone have a question? Okay. Oh, I'm sorry. So what do you mean, Dr. Trigg, is that about I'm sorry, can you clarify your question? For Dr. Shaw, no, there's no data on long-term safety yet for long-acting growth hormone. I mean, the concern obviously is, that potential that we could have high supraphysiologic IGF-1 levels, which is something that we're going to have to continue to watch. I think, remind me, Paul, on Skytrofa, what was the SD at the top for for Skytrofa for IGF-1s?
So the mean, the calculated mean over the week was about 0.5, and the cost was just under 2.
Okay.
I think the mean week was what, 4 point something. I can't remember.
Okay, so the mean was about 1 point something, so it wasn't extremely high from that standpoint. For Dr. Silverman, as I understand it from talking with the Novo people, if there's anyone from Novo in here, please correct me if I'm wrong, but somapacitan is approved, but is not yet on market in the United States for adult growth hormone deficiency. Okay, I'm giving the thumbs up that I'm telling you correct at that point. And yes, I agree with you, Dr. Trugestat, that I think the promise, and for me, one of the things that I'm waiting for somapacitan specifically is for transitioning young adults. You know, particularly I have some that are still followed by oncology and, you know, they've graduated from high school and trying to move on with their lives. And it's hard for them to adhere to multiple, you know, hormone replacement.